And this was first recognized by Terry back in 1942, so many years back, that retinopathy prematurely was recognized. Essentially, it's a disorder of retinal vascularization in the premature baby, and it's still remaining a leading cause of childhood blindness. Here is a bit of the historical perspective. And in 1940, the oxygen was introduced to support the premature baby. And it was great, so the children who want to mature were able to survive. But that, at the same time, increases, recognize the oxygen is a cause for our premature retinopathy of prematurity. So that was actually the first epidemic of retinopathy of prematurity. And then, because they realized the oxygen is a culprit, so they start to reduce the oxygen in the 50s. And that certainly helped to reduce the number of blind children suffering from IOP. But unfortunately, it also means that there's increased incidence of infant mortality and increased incidence of cerebral palsy because of the restricted oxygen for those premature babies. And then between the 50 and the 60, what happened is that now they were able to monitor the arterial oxygen level, and they were able to titrate the oxygen more accurately. And so at that point, there is we can reduce the exposure to over high oxygen content. And so there were more survival of the premature baby at this point. And with that, more children were able to survive the low birth rate. And that increases the opportunity for children to develop IOP, not because of the treatment, but because we're able to make them survive. So that is the second epidemic of the IOP because of the better management of these complications. Now we're looking at the third epidemic of IOP. The red area are those in high risk of IOP, and the green are the developed countries such as in Canada, in the US, and Europe, and Australia. And the reason why that is in the middle-income groups, such as places in India and in Vietnam, you have now increased or improved your health facilities, and therefore you have more children who are able to survive with early birth and low birth weight. And the difficulty is that there's quite a variations of the health facility between places, and also there's no standardization of screening and treatments of IOP. And for that reason, with the increased rate of prematurity and the poor delivery of the care, we definitely will have problems. So then I'm very glad that some of you who are not doing IOP treatment screening are interested in this, because soon enough that you'll be called upon to do that, because you're going to have more children in Vietnam who can survive young, early, and develop IOP. So any conditions is important to be able to classify them and describe them, because this way between experts you're able to tell each other what conditions and how severe the patient is. So in the early, I think in the 1984, in the early 80s, a group of ophthalmologists from 11 countries decided to develop an international classification of IOP. And the purpose is to describe the locations of the retinopathy and the extent, the location in terms of the given zones, and the extent depends on the region, the area that's involved. And the divide is zone 1, just the circle that's drawn from the center of the disc of 2, kind of the distance from the fovea to the optic disc. Twice of that become the diameter and draw a circle of it. And the zone 2 is from the this basic from this guy. Can we get some battery for this one? And then circle from the nasal retina, nasal aura. And then zone 3 is what's the remaining of the retina. And the stages is the severity of the IOP. And you can see this is the early stages of IOP. It's what we call the demarcation line. You can see the area of the vascular retina and the avascular retina. And you can see the abnormal vessel that's developing there. And stage 2, thank you. Stage 2 is the ridge. You can see that right there. You have that little elevations of the leading front of the avascular and the vascular retina. And this part is avascular, this is the vascular retina. And stage 3 is when you actually have this proliferations of neovascularization at the edge. So not only that there's a ridge, but this is pink, red, and it's supplied by vessels, and it is active. And quite often you may even see hemorrhages associated with that. And this is a high magnification, so you can see the vascularizations. So this is extraretinal proliferations and a little hemorrhages here. And stage 4 is if the condition becomes more advanced, you're going to get a partial retinal detachment. And if it's only involving the retina outside the macula, it's A, and if it's involving the macula, then it's called B. So 4B is, in this case here, that the macula is also being involved with the localized retinal detachment. In the more advanced cases of retinopathy or prematurity, you get a total retinal detachment, and you can have a combination of either tractional, as the picture shown here, or exudative retinal detachment. And this is what you don't want to see in prematurity, because this is the most advanced and most difficult forms of IOP. In addition, they also describe the conditions called plus disease. Essentially, it's describing the severity of the ischemia in the eye, and it's defined by the dilation and tortuosity of the retinal vessels. And if you have a pus disease, then it's the presence of those changes in at least 2 quadrants of the retina. And you can also have, not only limited to the posterior segment, you can have engorgements of the retinal vessels, iris vessels, and that is also a form of pus disease. And when that happens, the pupil become rigid, they don't move as well. And sometimes you also have vitreous haze because of the oozing of those vessels, causing the visualization difficult of the vitreous. After the classification, then we are now interested if there's a way to treat it. And back in the 90s, this is the multi-center prior IOP study. And they defined the cases that will be beneficial to the treatment. They call them threshold. And the threshold is defined to identify those cases that's likely to advance into more severe forms of IOP, and that can be blindness. And they decided if they intervene during this time, and what are they? Well, if there is a 5 contiguous hours of retinopathy prematurity in stage 3, and with the presence of pus, or cumulatively, we have 8 hours of stage 3 with pus disease. And in those cases, if they treated with prior, they were able to reduce the unfavorable outcome by 40% for the structural changes, meaning that they can prevent it from developing retinal detachment. With stage 3, the next stages is stage 4. Alternatively, they also were able to reduce the unfavorable outcome by 1/3 of the visions. So not only structurally, they were able to help these patients with IOP, they also help their visions. So that's with prior treatment. But the prior treatment is difficult and also is very inflammatory. So later on, laser was being introduced as another way to treat it and have similar, in fact, maybe better result because there's less inflammation to the eye. So we now do have a treatment that was effective to help to reduce the number of severe or threshold IOP to advance to a more severe form of IOP that visual losses or blindness. But in order to improve our management, we need to understand what happened to our key, why it happened. We know that it's a vascular problem, but why did it happen? Oxygen was a risk factor that was identified very early, but there are other factors that are not oxygen related, and we will talk about that. We are quite familiar with vascular endothelial growth factor, that's been talked about extensively through these 3 days. It's seen in AMD, it's seen in diabetes, but it's also a very important factor in the development of our key. This vascular endothelial growth factor, sometimes also described as hypoxia-inducible factor, is expressed in the mural cells and astrocyte in the leading edges of the capillaries. And that is responsible for the vessel to grow. So normally, you do have this vascular endothelial growth factor to stimulate the growth of the normal vessels. So not all VEGF is supposed to be pathological. Okay? So we needed to have normal vascular growth. The difficulty was that in eye that has retinopathy prematurity, there is a disruption in the regulations of the VEGF within that eye, and that's what's causing the revascularization from the IOP. And in fact, when they take vitreous from prematurity that has proliferative changes of IOP in stage 3 onward, they was able to find there was a high level of VEGF in those patients, in those babies. There's also another growth factor that you may not have paid attention to. It's called insulin-like growth factors. This is another growth factor that's different from the VEGF, but it's important for the development of the endothelial cells and the development of the retinal vessels. It's part of the, it works together with the VEGF. And this insulin-like growth factor does not stimulate by the hypoxia. It's nothing related to the oxygens. So whether it's low oxygen, high oxygen, it has no effect to it. It is just being produced in the body to promote the growth of vessels. And it is low in baby who are born premature and without IOP. And over time, it does increase because the body, the children who are born premature will make that. And when they first born, it is made from the mom, from the mother. It's from the placenta and from the fluid that was the amniotic fluid that was supported. But the child, as they grow older, they were able to produce this insulin growth factor. So Lois Smith is the one who proposed this biphasic development of retinopathy prematurity. So normally, the blood vessel will grow, keep going until it reaches horizontal at birth. That's what's happened. But when the baby was born premature, they were exposed to a higher oxygen level than they normally inside the tummy, because they're breathing the oxygen in the environment. In fact, in some instances, we give them extra oxygen to help them to survive the extra-uterine environment. That extra oxygen we describe as hyperoxia, high oxygen level than what is inside the tummy. That oxygen level will suppress the blood vessel from growing because it causes vasoconstriction. We all know oxygen causes vasoconstrictions. And on top of that, the placental and amniotic fluid, the insulin growth factors, were made at the time when they were born, but they don't have any more. Once they were born, the child left the tummy, you have no more placental and amniotic insulin growth factor to support the development of vessels. So at this particular point, the blood vessel actually stopped growing. As the retina here starts to become more mature, there is an increase of metabolic demand. We create a hypoxic environment, and it will upregulate the VEGF. And in the body, the liver of that baby will start making insulin growth factors. With the combinations of increasing both the insulin growth factors and the VEGF, now we have a stimulation to have the new vessel to grow. Unfortunately, those vessels are So by intervening here with the anti-VEGF, you can prevent the development of these abnormal blue vessels that are driven by the VEGF and the IGF. So we know about oxygen is a very important factor for the retinopathy prematurity development. So there are studies being done to look at how much that is involved in the development. So there's a study called Stop IOP, and they add extra oxygen to the child during the after they were born in the intensive care nursery, and they found that the added oxygen was not a risk factor. Interestingly, so in fact, I will show you a few more studies that seems to be contradictions, different report from different studies showing that oxygen may play or may not play a role. Hope IOP is another study. They also found that the higher oxygen level does not seem to affect the later phase of the IOP. On the other hand, one of the studies that was done trying to keep the oxygen level at a very tight control, about 83 to 93%. And they found that if they were able to keep that tight control, they were having a better result, meaning that less IOP developed in those children. So they were able to reduce incidence of IOP. So what I meant to show you here is that the oxygen seems to have a role, but we do not know exactly the role of it, because there seems to be some contradictory studies showing that our oxygen sometimes actually help to, if you control it tightly, but sometimes it really doesn't seem to matter. So up until this point, we have laser or cryo treatment that are effective to reduce the progressions of IOP. So how can we improve the management of that other than just treat them? So the early referral will be very helpful to identify the child earlier so that you can intervene early. And that can be done by either digital imaging using fundus photograph as a screening, especially in cases where there is difficult access to specialists. I'm going to talk about ET-IOP, so the early treatment IOP. The question is, can you treat? Is there any benefit to treat them before they develop threshold? Because the study that was done with the prior IOP the treatment was done only when the child reached threshold. So the question really wanted to find out is, can you treat them before the threshold has developed? And is the treatment, can we modify the treatment to make the treatment more effective? So Banash showed that in the publication, if you give a confluent laser, meaning that the lasers are overlapping or very close together, they were having a better result to control the threshold IOP, to reduce the rate of progression by 4 versus almost 30%. So by giving, a treatment like this is considered inadequate because you have spaces between them. A treatment like this of near confluent laser will be more effective in reducing the progressions. So the study suggests that you need to be very aggressive in the laser, and you need to avoid any spaces between them to be effective. And the effectiveness is significant from a 30% to 4% changes in reducing the progressions of the retinopathy prematurity. We are quite familiar with RetCam, which has really revolutionized the management of IOP, because no longer you depend on the drawing. I don't know how many of you draw fundus. I have to say, the drawing looks awful for the majority of people. So if I have a referral, I look at the drawing from another doctor, another ophthalmologist, or even from my own institution. I have no idea what it's very good. But the RetCam picture allows you to monitor progressions, and now you can actually teach not only another ophthalmologist, but the nurses who are important in caring of those patients. And if they understand the progressions or the importance of these conditions, they are more eager to help you. Because in the past, I remember when I go to the NICU, the nurse saw me and said, "Oh, you're coming here to torture the baby." They have no idea what I was trying to see. They have no idea what I'm trying to do. But now, they actually have the opportunity to know The opportunity to use this camera system will allow you to do the screening in places where the expertise is not available. And it's important to understand that IOP, if you mistreat them early, you end up with a blind treatment. The cost is significant. So there was a photo IOP study. They were looking at children who are born quite premature and a low birth weight, and they found that the webcam picture has a very high sensitivity and relatively reasonable, not a very good specificity or a third for clinical significant IOP, meaning that those that will require treatment. But this is actually very good in identifying those for early IOP, the pre-threshold IOP. And of course, you require high imaging quality to use them. So following that, in 2003, we have the early treatment PT-IOP study that was published in Archives. The question was, can treatment before threshold IOP develop help? Can we start earlier? And if we can start earlier, which are the babies that will benefit from earlier treatment? In the study, they were identifying those so-called pre-threshold high-risk baby, and they call it type 1. And who are they? They are baby with zone 1, any IOP, any stage of IOP with plus disease, or stage 3 IOP. So if the baby in zone 1, the first circle, has any IOP, most important, if they have plus disease, doesn't matter what stages, whether it's 1, 2, 3, they are considered as high risk. Or if they are zone 2, meaning that they are going into the second circle, if they have plus disease, whether they have stage 2 or stage 3, is also considered as high risk pre-threshold. And in those identified as type 1 or high risk pre-threshold, if they get treatment early, you can see the structural outcome. The conventional treatment has 15% progression to unfavorable outcome, meaning that they will develop tractions, retinal detachment, compared to those treated with early. So that's almost near, not quite, 40% reductions in the progressions or the worsening of the structural outcome by treating them early in type 1 pre-threshold. And the vision also improved. Those conventionally treated, 19%, almost 20% developed unfavorable visual outcome, compared to 14 or 15% treated with early when they develop high-risk threshold. So in summary, the ET-IOP basically has now identified a high-risk pre-threshold. So you don't have to wait for a threshold to develop. You don't have to wait for the more severe advanced IOP to intervene. And those who benefit in zone 1 with plus disease, or zone 2, plus with stage 2 or stage 3. There's also another condition for aggressive posterior IOP. Here's an example. What it is that some cases can start with immature vessels and progress from immature vessel to stage 3, skipping 1 and 2. And those babies was found to be very bad to develop this kind of condition from this so-called aggressive posterior IOP. So this is a tractional retinal detachment that developed. So the same group of ophthalmologists, not quite the same group from the international, early in the 1984, but subsequently they also want to identify this aggressive group of posterior IOP, and sometimes refer as rushing it very quickly, and see this need to pay special attention. And in these classifications of aggressive posterior IOP in zone 1 IOP, we also identified a newer description called pre-plus. Remember, plus disease is tortuosity and dilations of retinal vessel in 2 quadrants. But what happens if it's only in 1 quadrant, then it's called pre-plus. Maybe just telling you that they are not that bad, they're not that severe, but yet they're starting to develop early ischemic changes. So what is the posterior disease? Essentially, we're looking at zone 1 and a bit of the zone 2. This is what posterior disease is. But how do you identify it? The way to identify it simply, you use a 25 or 28 diopter lens and you look into the fundus. Whatever you see, the area that's covered within that kind of viewing through the lens is what we describe as posterior plus aggressive posterior diseases. And the reason why we need to identify them is that this patient, and again, like this is a typical plus, and this is 1 quadrant of tortuosity, and so this is called P plus. And what is important to identify them is that this group of patients with aggressive posterior IOP, and the last picture was another kind of P plus, just mild tortuosity in 1 quadrant. And patient with aggressive posterior IOP with plus disease, and those are the different forms. You can see that the vessel can get enlarged, you can actually sometimes get hemorrhages. And you can see these, this is zone 1, this is this macula, and this is the distance to it. And here is a collage of pictures of a with the red cam. And you can see when you put them together, you can see the severe IOP that's developing there. And this baby, if you don't do anything right away, they will develop very advanced IOP. In addition to that though, because of the use of fluorescein angiogram, now you also identify new forms of neovascularizations, what we call the fat neovascularizations. Remember, I explained to you the stage 3 IOP is extraretinal proliferations. So we identify that as a high-risk factor. But with the use of fluorescein angiogram, we actually identify this so-called flat stage 3 IOP. They are as bad, especially in a posterior aggressive forms of IOP. They are equally bad. So this will require treatment. And in fact, this requires more than laser or cryo treatment, because laser or cryo treatment in this group of patients may not be sufficient. And that's when people start looking at other means to treat it. So the use of anti-VEGF start coming in the horizon during that time, and people start looking at this, realizing VEGF is an important risk factor. So this study was done in 2008, not long after the ETROD study. They looked at 18 rabbits who was given different dosage and different interval of the avastin. And they found that there was no sign of toxicity with that. So there seemed to be a reassurance of some safety. You understand though, baby or early kind of young retina may be more susceptible than the older AMD patient with diabetes. So we don't know that. So this was opening the way to look at possibility it can be used. So around the same time, this was also actually used in children with IOP that was thought to be unresponsive to treatment. So there was 10 with 5 infant, 7 had initial laser treatment for the stage 3 plus, 2 of them in zone 1 and 5 in zone 2. And they were progressive, so they were treated also with laser and avastin. And then there was 2 of the 5 infant, it was treated with cryo, with stage 3 in zone 2, who progressed to 4B a couple of weeks later, and they were treated with additional laser and avastin. And then 1 presented with stage 4 and treated with avastin right away. And what's important is all of the stage 4 eye in this study, the disease regressed with the treatment. Unfortunately though, there was macular drag because they were late in getting the treatment. Carlos, a cattle from Mexico, he decided to take it a little bit further. He looked at 10 patients, 49 with stage 3 with plus disease, no treatment. And then another group that was 3 patients who already developed stage 4 A and B after laser treatment. So after treatment, there was still progression, and they found that 17 out of the 18 improved. Only only 1 out of 89 require retraction. So now people start to get more confidence that the anti-VEGF is helping the more active IOP. At the same time, Honda is now giving us a warning. He observed that when you give Avastin in stage 4 IOP, the neovascularization regress very quickly. When that happens, it can actually cause fibrosis and tractions. And within a week, from a stage 4 to develop stage 5. So that is not completely so harmless to use the anti-VEGF. There is a potential risk, especially there's already a traction, an active traction more importantly. So if you are going to do that, then you must be prepared to do surgery in this child, or this group of babies, if you decided to inject anti-VEGF. Because if you don't, you actually make things worse. So come along, I'm sure you already know about this kind of landmark study that was published in 2011. So by now it's a little old news. It was published in New England Journal of Medicine. They were looking at the efficacy of intravitreal bevacizumab for stage 3 plus retinopathy prematurity. So they give the acronyms for BEAT IOP. So basically it's a multi-center randomized clinical trial. They were looking at zone 1 or 0, zone 2, stage 3 plus IOP. So those are the more aggressive IOP. We know that those will develop to very bad outcome if they don't get treated early. In fact, even with treatment with prior or laser, they sometimes progress to advanced forms of IOP. So they were given the conventional laser or the half of the adult dose of Avastin. And their primary outcome is look at if the IOP will require more treatment before 54 weeks of postmenstrual age. And there was quite a number of patients that were randomized, 150 infants, 300 eyes. So the result was that those that were treated with bevacizumab, only 4% will require additional treatment. On the other hand, those treated with laser, near a quarter of them will need additional treatment. So that really proved the fact that Avastin was very helpful to reduce the activity of the retinopathy prematurity in these aggressive forms, these aggressive groups. And when they looked at the subgroup analysis, they found that this is, as I just said, is very effective in zone 1. But there wasn't enough number to look at those in zone 2. Okay, because simply the number that was in the study was not high enough. Some of the off side effect, as we expected, is that in laser, it causes peripheral retinal destruction, it causes more inflammations. In bevacizumab, there's the potential risk of infection, although it wasn't a problem in the study. Another observation they've seen is that these two pictures, this child with zone 1 and active stage 3 treated with laser, and the vessel, the retinal vessel, the normal retinal vessel stopped going beyond where the laser treatment is, where the retina basically completely destroyed. So there is no stimulation for the vessel to go further. So the vessel stopped there. On the other hand, this very aggressive plus disease with stage 1 IOP treated with bevacizumab. So after the treatment, the vessel continued to grow because the retina in the previously avascular zone were able to survive because there was no destruction caused by the laser. So in summary, what this BEAT IOP study is showing that bevacizumab is more effective than laser, particularly in zone 1, stage 3 IOP. So remember this though, this is not for zone 2 or zone 3. This is for very aggressive forms of IOP. And the study we were not able to prove that those less aggressive ones, Avastin is better. And the vessel can continue to grow in the bevacizumab group, in the Avastin group, but not with the laser. The laser destroys the retina and takes away the stimulations for the retina to grow. The difficulty though is that we don't know whether it is safe in the long run. We know that Avastin has its systemic side effects, potential systemic side effects, but the number of patients, which 300 times, is not enough to tell the answer to it. And especially this is important in this developing child where organogenesis and angiogenesis is an important part of their growth. Within the study, they actually look at how many babies need to be looked at the systemic side effect. They come up the numbers. You need 2,800 babies in order to look at 1.5 retinal risk with the use of retinopathy. So I don't think we'll ever get an answer to that question. But it's important that we know, and from other literature, that bevacizumab do get into the systemic circulation. In fact, we know that the peak serum level happened 1 week after the injections. About 3% of the peak level from the aqueous is found in the serum. So we know that the drug does get into the systemic circulation. It's not staying in the eye alone. And the half-life lasts for 4 to 5 days. And we can see that in a study using the newborn baby, such as the injection early in life lead to increased peak, so meaning that the younger the baby, in particular in the rapid study, the probably less developed of the blood ocular barrier, allowing the drug to get into the systemic circulation easier. And we are looking at treating this premature baby who probably has also immature blood ocular barrier, which means the systemic exposure to the drug is significantly high. The only good thing is that most babies only require 1 injection, different than diabetic patients and different than the AMD patients who only get repeated injections. And this is a small dose that we use, what half of what the adult dose is. And so far there hasn't been any significant report that has come out from the treatment. Because since the RD study, there's a number of studies being done and case series to show that it is effective. And so far, fortunately, there's no sign of any safety issues. But we still need to follow this purification very carefully. This is just a reminder that an embryo, a baby that developed, require the VEGF, the healthy, the normal, the good VEGF for bone development, reproductive organ, the retina, even cornea, blood vessels, and etc. So blocking VEGF can, if you block it effectively, you can actually cure the baby potentially. Just that so far, the small dose, we are lucky. So this is summarize the optimal care for infant who are at risk of IOP. Prevention. We're not sure how often should be, whether we should tightly control it. And we know that it does influence the outcome, but it's not the only factor that determines whether the child will develop IOP. Early recognition with digital imaging, especially using telemedicine in an area that has poor access, will be very helpful to manage those babies, to identify those require treatment and get them referred to the tertiary center where the treatment is available. The near-confluent laser or the ETRP, the early treatment IOP, identify those groups that can be treated earlier, and a more tightly laser area will help to improve the outcome. And the use of anti-VEGF, especially for the more aggressive form, the zone 1 IOP, has been very kind of revolutionized the management, because those patients with the progressive or aggressive posterior IOP now have a chance to survive without having to develop a more advanced form of IOP. But what if, despite the treatment, we develop stage 4 IOP? In fact, this happens even though we treat them very aggressively. In the ETRP study, 12% of those that was treated in a timely fashion still developed retinal detachment. So we're going to, for the next 2 minutes, we're going to talk about managing stage 4 and stage 5 IOP. Hopefully, you never see them. Because if you do it right, up to now, you should not see any stage 4 and stage 5. But that's not true. You still see some. You might still see some. So what happens when you do see some? Most of the misconception is that you should wait till the macula is detached, meaning that you should wait till they are 4B before you intervene. That sometimes may be a little bit too late because you already have macular detachment, you already have traction formed. So the purpose of the interventions or management of stage 4 IOP is to try to cause minimal amount of distortions in the posterior IOP and have a total retinal detachment, and more importantly, to preserve central fixations. And in doing so, you also try to preserve the lens, because removing the lens in the surgery will increase the difficulty with amblyopia. And most importantly, stop the progressions of the IOP. So what are the surgical management? And they are well documented. Tracy and Capone has advocated lens-sparing vitrectomy as a way to manage stage 4 IOP. And the purpose is to remove the traction that is created by the IOP and therefore stop them from progressing. So vitrectomy has been the most favorable treatment, or most favorite treatment. Skull buckle has been also used, especially if there's anterior tractions. But the disadvantage of skull buckle is that it can cause myopia, especially if you only do surgery in one eye, that will even exaggerate the problem of anisometropia and amblyopia. And we need a second surgery to either remove or cut the buckle because the eye grows, okay? Especially at this early stages. So here's an example of an advanced form of stage 4 IOP. You can see the vitreous is organized and creating tractions. You know this is stage 4 because you see this peripheral laser, the retina is attached, and so is here. So it's not a total retinal detachment. What is meant by lens-sparing vitrectomy? Essentially that the surgery is done with the intention not to damage the lens. So the children's lens is usually quite big in proportions to the rest of the eye. So the instrument manipulation should be minimal to avoid crossing the midline to damage the lens. So you should restrict yourself to the area within and away from the midline. Remember the patient that was, I just showed you, this is after the surgery. You can remove all the tractions. You can see this laser scar, you can now see the macula is unaffected and the detachment as we saw. So this child will have a significant good chance of visual recovery. So here are some of the study that was that's published. You can see that for the anatomical success, very good, 80 to 90% successful rate. And for the visual outcome, you pay attention back here. On average, the log mark post-surgery is 2058. Some get 2200, but some can get up to 2080 or better visions. So stage 4 IOP is fixable and has good visual outcome. And don't wait till they have macular tractions. Should be considered early treatment. What was stage 5? When you have total retinal detachment, most of the time people give up on these cases because when you reach this, it's usually very advanced. And there are ways to fix it, either in the past open sky, and more, of course, more people prefer close retractomy. This was the prior IOP study. What they show in the study, 120 eyes, those eyes that underwent retractomy, 21%, over a quarter of them will have retina reattachment. If they didn't have retractomy, only 3%, one eye out of the 56, has some part of the retina detached. So surgery, despite these advanced forms of IOP, helps. And one of the eye has some vision improvement. So what's the principle of doing stage 5 IOP? Is that you want to restore the posterior fold and maximize the area of retinal detachment. Lensectomy is usually required because of the traction that developed And you need to have a very aggressive postoperative refractive therapy in order to improve visions in this group of patients. And remember, there is a time required to be aggressive in this postoperative rehabilitation for them. What are the full prognosticating factor or full prognostic features for the stage 5 IOP? If you have a posterior narrow funnel, they don't do so well. If they already have, if they're still active at the time of the surgery, they also don't do so well. And because that means they're still active VEGF driven, and they will probably do more tractions even after the surgery. Let me share with you a case. Happened to come from this country. The child is a 1.5, was referred to Toronto. That's when I saw this last year. He's from the Ho Chi Minh City. He was born at 28 weeks, 1.1 kilograms. It was not bad. He was treated with laser to both eyes and repeated because there were signs of progressions. But despite the treatment, this is what happened to the right eye and the left eye. The left eye basically slices with corneal edema. It's very poor view of the posterior segment. And this is the right eye with sleek eye and no view to the fundus. And this is the ultrasound. The left eye you can see smaller, and you have a post-fundal retinal detachment. The left eye has a posterior post-fundal detachment. So the first thing that needs to be done is to free up the adhesions. So this is just the surgical video, and the iris retractors are very helpful to evaluate the pupil. You see, this is done with the anterior infusions because we know that there's an anterior traction retinal detachment. So after the mastectomy was completed with the vitreous cover, then this retrolental fibrosis, that fibrous tissue that's behind the lens, that involve the lens capsule, need to be cut with a bimanual fashions. And it's important to remove this in a very meticulous fashion. And the step that we do is we'll call segmentation, meaning that we cut the pieces in smaller pieces. And although we try to do something with laminations, but to remove these scar tissues from the attached retina sometimes is very difficult. The important part of the surgery is that you do not try to be too aggressive, because the minute you make a hole in the retina, the whole game changes. Because at this point it's a tractional retinal detachment, but if you make a hole in the retina, then you become a retinal retinal detachment. So once you clear all that, then I use Helon to open up the posterior segment. But because there was still quite a lot of anterior tractions, because there's still a lot of anterior tractions, which I cannot completely relieve, so I decided to put a buckle to relieve that anterior tractions. Because more aggressive dissections of anterior segment will not be very effective and more chance of breaking the retina and creating a hole. So this is the postoperative features. Now, for most of the medical retina, or people who doesn't do surgical retina, this looks like ugly pictures. But for a pediatric visual retinal surgeon, this is a beautiful picture. The reason why it's beautiful, you can see there's optic nerve, the vessels, macula somewhere here. There's a high buccal, but the retina is attached on the buccal. There's a lot of tractions. There's some retinal fibrosis. There's still some residual anterior preretinal fibrosis. Remember, this is the preoperative picture when you can't even see the optic nerve or the macula. So despite what it looks like horrible pictures for most people who are not surgical retina, I think this is, for me, was wonderful. After one surgery, a single intervention. This is ultrasound showing the buccal indentation, and you can see that the retina is completely reattached, especially in the posterior pole. And here, another view of the bumper. One other case, this is older, sent from China, with bilateral stage 5 IOP. And this one, unfortunately, was a kind of mismanagement. It was never got any treatment at all. Okay, so you can see again, in close fundal retinal detachment, this is what it looks like. It looks pretty awful. And this is the right and the left eye. You can see the close fundal detachment retractions. And this is what happened after the surgery. So this child will have a chance to see. May not necessarily see very well. So how about when they see? Here's a study that was done published recently in 2008, I think. And you can see that for those 9 babies that has no non-embryotic eye, 2080, 2400, 2080, 21, 2016, 1600. Remember, these are children who have been considered as blind. It's considered nothing can be done. They were open funnel stage 5 IOP. Okay? So not necessary to give up those patients. And this study was using also triamcinolone as a way to try to reduce postoperative inflammation. I'm only interested that they were able to get 60% reattachment of the retina, which is pretty good because none of the child who did not have treatment reattached as expected, and some of them do get vision. Of course, we are not looking at dramatic visions, and I think the study that was shown earlier showed very significant improvement in the visions, but most of the time I'll explain to the parent that what I'm trying to do is preserve the eye and give an opportunity some forms of visions, and unfortunately, they will have to work hard with the child to try to improve whatever residual vision that's there. Don't wait for the stage 4 to become a macular demorph detachment. Intervene early, but make sure you can keep the lens out if possible, because by leaving the lens in, doing a lens sparing vitrectomy, you will have a better chance to rehabilitate this child and have less problem with ambulance. Thank you. Questions? Since only 6 of you do RP, so I don't think, there.
I just wondering if the case of just for the stage 4 RP that you do a vitrectomy and you show a picture that the patient have a laser. So did you do a laser after that?
The child actually has very good laser done. Despite laser, there was the attraction development. One issue about laser is that it can cause a lot of inflammation. I think that was part of the reasons. And at the time of the surgery, we did a little bit more laser. I didn't add more laser, because there was already very good treatment that was done. And as I said, I think the reason why it progressed is because there was a lot of post-laser inflammation that created more traction. And so in that particular case, I didn't have to do a lot more laser intraoperatively. And there was also pre-Avastin era. It was before that. So Avastin was not a consideration in those. And in that particular case, Avastin would be a bad choice to use too, because you can't see the retina well, and I think if you inject that case, you can usually become stage 5. So I think in that particular case, you probably go in, fill up the vitreous tractions, and put gas for air.
And how about the IOP, the crunch IOP? Do you treat it in the same way as stage 4?
So the rushed stage zone 1, we call it out.
Yeah, and then it's different crunches IOP?
Right. So if you have a lot of fibrosis that's already developed, then I think you treat it with vitrectomy. Don't worry about the anti-VEGF. I think that the anti-VEGF that's the added will actually make the fibrosis worse. I think anti-VEGF is a double-edged rapid progression of the fibrosis. If you feel that there's still very active neovascularization, you need to do something before surgery, then you just need to see the patients very closely every day or every second day and book surgery within a week of the injection, because you don't want it to be very, and you don't want it to progress very aggressively and then come up with a much more difficult configuration to try to operate.
Right. Well, I think we've come to the end of a very long day. And I'd like to thank Professor Lam in the usual manner. Excellent lecture. It's my pleasant duty now to close the 10th ISASO Asia meeting here in Hanoi. And on behalf of ISASO Asia, I'd like to thank all the faculty members who have come from the United States, Europe, Hong Kong, Australia, and also from Singapore, and of course the local faculty from Vietnam, who have helped us tremendously in providing with excellent material for the 4 days that we've been here. So on behalf of ISASO Asia, I'd like to thank all the faculty for their contribution, their time, and the tremendous efforts that they have put in to prepare for their lectures. And we thank them in our usual manner. Thank you. Also, I'd like to also thank the artists, both the global as well as the local Vietnam team, who's actually in Singapore, but based in Basel. Thank you very much for all the support. Here, this beautiful city with such nice weather. Tonight we are going out to eat some local Vietnamese food. And of course, our event organizers who have helped to put everything together, Hazel and Megan, the hotel, Pan Pacific. I think the facilities here are excellent. They have helped us a lot so that everything can go smoothly. And of course, I'd like to thank all of you. If you are not here, then we are also not, we won't be here as well. All right? Thank you very much for all your attendance and your patience and perseverance to the last stage. Of course, we need your MCQs. Then please hand them as you go out. It's okay. There's no scoring here. It's just for us to make sure that our lectures are understood so that you understand the concept. And then just hand them up together with your feedback. As I mentioned this morning, your feedback is very important to us. We plan each course based on what feedback we receive so that we can make it better, as I said, for future courses. So once again, ladies and gentlemen, thank you very much. And I hope to see you all again in Singapore for the CPO meeting in March of next year. Thank you.